Okay, guys, good morning. This boot camp is going to go over nursing ethical principles. It's going to go over infection and pain, musculoskeletal. Hopefully, we'll have some time to get to cardiac. If not, that'll be the next one. So let's start with, nursing ethical principles, and this should be short and sweet. The principles that you need to know: autonomy. Autonomy means that the patient is an active participant in his or her plan of care. So if you have a patient that wants a shower in the afternoon because that's when they typically shower, then do it. You do your best to accommodate your patients within reason, right? So, but if your patient says, I want you to put me in a bathtub full of ice cubes 5 times a day, you wouldn't do that. And that would be exerting the nursing ethical principle of non-maleficence. Do no harm. So you're not doing anything, but by not doing it, you're not hurting them. So that's non-maleficence. Beneficence is the act of doing good. It's an action. You are doing something. So in other words, you are resuscitating someone who has, their heart stopped beating or they stopped breathing, saving someone from drowning, blah, blah, blah. That is beneficence, doing something good. It's an action. And then we have veracity. And I always remember in vino veritas, which means in wine, there is truth. So veracity means don't lie. You tell the truth, no matter what. You never lie to your patients. We have justice. And I remember that one. And justice for all. Al Pacino movie. I love Al Pacino. So, and justice for all. Justice means that as nurses, we don't judge, right? Everybody gets the same treatment, regardless of who you are, what color your skin is, what religion you are, your choices that you make. I'm not a judge. I'm not a cop. I'm not a jury. I don't care if they say you're a criminal. That's not my problem. I'm your nurse, right? So everybody gets treated the same. And then I'll take it a step further. And I always use the example that you're a nurse in a rural setting and you have a pharmaceutical company that says, you know what, we're going to donate 50 glucometers or 50 insulin pumps or some type of equipment. But you have 200 patients that could use it. How do you decide who you give those things to? It's got to be completely fair, non-judgmental, and unbiased. So a lottery, throw all the names into a bowl or a hat or something, pull a name out, right? You can't decide based on need because who gets to decide what's needy? You understand? So understand that justice means fair treatment, equitable distribution across the board. Everybody gets treated the same. Okay? We have utilitarianism. When you see the word utilitarianism as an ethical principle, your brain needs to say it's all about the greatest good for the most amount of people, the outcomes. Doesn't matter how you got to the outcome. Maybe it was a little shady. Doesn't matter. Did you have the most amount of positive outcomes for the greatest amount of people, right? That's what that means. Utilitarianism is all about getting to the right outcome for the most amount of people, okay? So I give the example, there's a treatment for cancer in another country. And of course, so it's not FDA approved or anything, but it's been having some good results. And you have patients that have that type of cancer and they're not doing well. And you tell them about it and you're like, listen, I can't officially, recommend this, but I will share the information with you. Do with it what you will. And those patients go to that other country, they get that treatment and they all get better. Boom. Utilitarianism. I got a bunch of people well, even though, a lot of people would say, oh, well, that's not FDA approved in America. Did it work? Yes? Cool. Right? That's utilitarianism. Let's see, justice, veracity, fidelity. People get divorced because of something called infidelity. So infidelity means you're cheating on somebody, right? So you can't be trusted. Fidelity means you can be trusted. You are trustworthy, right? So if you tell somebody that you're coming back in 20 minutes, come back in 20 minutes, right? Don't tell them that just to shut them up, right? Don't placate them. Don't pacify them. Tell the truth. If you can't get back to that room for an hour or more, tell the truth and then they're going to trust you. So that's actually a combination of veracity and fidelity. So those are the nursing ethical principles. Those are the standards that have to be followed, right? The American Nurses Association puts forth a statement about nursing ethics and standards, and those are the principles in them. The Board of Nursing may question you about one of them, and ATI may question you about them. Let's recap and talk about HIPAA for a minute, and it's the Health Insurance Portability and Accountability Act. HIPAA, so it's not two P's, it's two A's. And HIPAA just means it's client confidentiality. Protected medical information doesn't get shared unless it is with someone who is directly involved with that patient. So the insurance company may have access to the electronic medical records if they're paying for the care. They're involved. The doctors, the nurse practitioners, the nurses, the therapies, speech therapy, occupational and physical therapy, a chaplain, a social worker. If they're involved in the care, they are permitted to have full access. Excuse me. Make sure you understand that when it comes to EMR, electronic medical records, you don't share your password with anybody. You always log off completely. If you're on a computer documenting and then you get distracted and somebody's calling, you need to do something, you must get off before you go take care of that issue. Okay. Real quick recap of advanced directives. Advanced directives are the umbrella term, and under advanced directives, you have two pieces of information. One of them is a living will, and the other one is healthcare surrogate or durable medical power of attorney. They are interchangeable. They mean the same thing. A healthcare surrogate is a durable medical power of attorney. It means that you have designated a person to speak for you if you are unable to make decisions or speak for yourself, right? So that's that. And then you have your living will. The living will is a document that writes what you want in the event you are terminal. I don't want or I do want mechanical ventilation. I don't want or I do want artificial feeding tube, okay? That is a living will. So the living will, durable medical power of attorney are components of advance directives, okay? Don't confuse them with a DNR. Advance directives, you don't need a doctor's order. You don't need an attorney. You don't need anything other than you can go online and get the document and you can fill it out yourself. It does need a witness, right? That's somebody that's objective, third party, just to witness that you're awake, alert, and oriented, and that you're not confused or nobody's holding a gun to your head saying, sign her, do that. Just like informed consent. When you're witnessing an informed consent, you're not witnessing the understanding. You're not witnessing that the surgeon explained everything he or she's responsible for. You are witnessing that the signature that the patient is providing indicates the patient is awake, alert, and oriented. They are not medicated and they're not confused or cognitively impaired, and that they're doing it of their own volition and free will, not under duress. Nobody's forcing them to sign that consent. So make sure you know that. I'm going to pause the recording for a minute. Okay, so informed consent, just to reiterate for the sake of the recording, the only thing that the nurse is witnessing when you witness an informed consent is the status of the patient that is signing. In other words, you are witnessing, you are attesting by co-signing, you're signing to say, hey, yeah, that patient was awake, alert, and oriented. Nobody was forcing the patient to sign. They weren't medicated. They weren't confused or demented. That's all. You are not attesting to the information provided by the surgeon. Okay? Understand that. Now, then you have a DNR. We'll talk about DNR, DNI, DNH. DNR, do not resuscitate. If my heart stops beating or I stop breathing, don't do anything. Okay? That requires a physician's order. So that is not something you can just like pull up on the internet and, yeah, I want to be a DNR. Physician's order is required for that. And DNI means do not intubate. And I always had a problem with that because Do not intubate. In other words, you can go ahead and resuscitate me, but if it gets to the point where you have to put a tube into me for me to breathe, stop right there. Don't intubate me, okay? And that needs a doctor's order. And DNH means do not hospitalize, which also, I mean, if you don't want to go to the hospital, then you probably don't want to be resuscitated or intubated either, right? But anyway, those things require a physician's actual order. And typically, just so you know, when somebody is a DNR, used to be back in the day that we could put it right on the front of their chart, but that's a HIPAA violation now. We can't do that. So many facilities will have like a color-coded system, and so the patient will have a bracelet, say, that's maybe yellow or red or some color where everyone universally understands if this resident has this color bracelet on, that means that they're a DNR. Because understand something, if you come down the hallway and a patient is lying on the floor, you are ethically, morally, and legally responsible to assist them as a nurse. Required. It's not like, well, I don't feel like it today. No, you're required. And if they're a DNR and you don't know it, that's not your fault. So you can't be held accountable. It's not like they can sue you afterwards and say, she resuscitated me and I was a DNR. Well, how the hell were you supposed to know, right? There would be no way for you to know that. So you are not held liable for that. And if you do resuscitate somebody, let's say you're walking down the street and you come upon, and this happened to me a couple times, most recent in Florida, homeless dude at a bus stop, you know, I'm going to stop and resuscitate him. I'm not going to just walk by. That's, you know what I mean? How do people do that? But anyway, you know, you break somebody's ribs, because if you're really doing CPR right, you got to push really hard to get their heart to beat. Okay. If you break their ribs, you can't get sued. Okay. You're alive, dude. You know, Merry Christmas. You just got a gift. So and it's under the Good Samaritan law that protects people from being sued for any consequence of a heroic action. So if I save your life, but I break your ribs while I'm doing it, you can't sue me because of that. Okay. Next, let's talk about pain and pain management, and we'll talk about the meds also. Remember a couple things. What is pain? Whatever your patient says it is. Pain assessment is the only subjective assessment that's documented as objective. So if I say to you, you tell me you're having pain, I need you to quantify the pain. In other words, put a number on it. 0 is no pain, 10 is excruciating pain. What number is your pain? If you tell me it's an 8, it's an 8. The end, right? So that is quantifying pain. You're putting a number on it. If you are qualifying pain, you're describing it. Is the pain stabbing, aching, throbbing, burning? What does it feel like, right? That's qualifying it. And then you're going to ask a lot more questions when we're talking about a pain assessment. What makes it better? What makes it worse? In other words, what are aggravating factors make it worse? What are precipitating events? I'm not talking about rain. In other words, you're telling me that you have pain in your left leg. Did something happen right before the pain started that may have caused the pain? Did you fall? Were you in an accident? What is the precipitating event that triggered the pain, if there is one? Okay. So there are lots of questions, and make sure you understand that the numeric scale is the one that I just discussed, 0 to 10. And that is only to be used with adults that are not cognitively impaired, right? Because they have to be able to understand the question and answer it. If you're dealing with somebody who is cognitively impaired or a child, then the Wong-Baker faces scale, and that's where there are all the faces, and they go from being, you know, happy, and then oh, very, very sad, crying, and everywhere in between. And you have the person or the child point to which one they feel like. That's the Wong-Baker faces scale. And then last but not least, you have the FLAC scale, and that's the FLACC. It's for infants. And that's an assessment of pain, because if you're assessing pain in a newborn or an infant, they can't talk to you and they can't point. So you're looking at their body language. You're looking at their crying, at their limb activity. Are they flaccid? You know, so make sure you know the difference in those scales. And that's in the pain PowerPoint, okay? We talk about management of pain, talk about pain medications. First one we'll talk about, and pain medications are analgesics. An analgesic is something that decreases pain. So we have, for the mild pain, things like acetaminophen, Tylenol, and that is an analgesic, reduces pain. It's an antipyretic, reduces fever. It is not an anti-inflammatory. Acetaminophen is not an anti-inflammatory. Okay? Acetaminophen maximum dosage is 3,000 milligrams or 3 grams in a 24-hour period. The biggest adverse effect, hepatotoxicity. So if someone has any problem with their liver damage, cirrhosis, one of the hepatitis is, you would be very careful and you may not give them acetaminophen. You may choose something different for them because of the problem with their liver already. You don't want to make their liver worse. If they're a drinker and they drink on a regular basis, acetaminophen's not for them. Throw them over the edge and shut their liver down, okay? Those are the things that you need to know about acetaminophen. Then we have acetylsalicylic acid, which is a salicylate, good old aspirin. Aspirin is an anti-inflammatory and an analgesic and an antipyretic and an antiplatelet aggregator. So it reduces pain, inflammation, and fever, and keeps your platelets from sticking together. So I could be giving you an aspirin a day because you had a heart attack, an MI, and I want to prevent you from having a blood clot. So if I give you an aspirin every day, your platelets won't clot together, right? Or I could be giving you aspirin because you have a fever. Remember, when I was a child, there was no Tylenol. All we had was aspirin. And so if you had kids that had, you know, a fever or an illness or virus or something, St. Joseph's aspirin for children, and it was orange flavored. It was disgusting. To this day, I can't drink anything orange flavored. Gross. Okay. And the other thing that's important with aspirin, you should never give aspirin to a child with a viral infection, the flu, right? Anything that's viral, because it can cause something called Reye's syndrome, R-E-Y-E, Reye's syndrome. Later on, it's a neurological disorder, okay? So no aspirin to children that are, you know, under the age of 18 that had a viral infection. And that's it for aspirin. Remember too that aspirin can cause GI bleeds. So people have an ulcer, peptic ulcer, gastric ulcer, you might want to be hesitant with that as well. And a sign of a GI bleed, black tarry stools called melena. You want to teach the patient to be on the lookout for that if they're using aspirin on a regular basis. Also NSAIDs, which brings us to our next classification. Non-steroidal anti-inflammatory drugs, NSAIDs, which are ibuprofen, Advil, Motrin, meloxicam, Mobic, celecoxib, Celebrex, and naproxen sodium, naproxen, which is Aleve. Those are all anti-inflammatory drugs. All of them decrease inflammation. All of them can cause a GI bleed. Celecoxib has 2 more that you need to know. If your patient is allergic to sulfonamides, they can't have celecoxib. And if your patient has any cardiac history of deep vein thrombosis, a DVT, or an MI, or any cardiac history, Celebrex, celecoxib is not the drug for them. Okay, so, and that's the NSAIDs. And then we'll get to the opioids. So if somebody's having moderate to severe pain, we have another classification of drugs called opioids. And in that classification, opioids, you have morphine, morphine sulfate, codeine, you have meperidine, which is Demerol, you have Dilaudid, you have hydrocodone, hydromorphone, OxyContin, oxycodone, right? Tramadol. Those are all opioids, and they all block pain in the brain, right? That's how they work. They block pain in the brain, and all of them share adverse effects. The big ones are respiratory depression, urinary retention, paralytic ileus. They can all cause constipation, but no one dies from that. Okay, so make sure you know opioids, respiratory depression. If the patient's respiratory rate, which is the first thing you should be assessing, if it's under 12, ooh, right? You don't want to give it. When we talk about urinary retention, you're looking at the patient's medical history. If they have BPH, benign prostatic hyperplasia or hypertrophy, that means their prostate has gotten enlarged and blocks the urethra, prevents them from urinating, can't empty their bladder, so they already have urinary retention. So you are not going to give an opioid that can cause urinary retention to somebody who already has a problem with urinary retention, right? And then the last one, paralytic ileus. When we talk about the digestive system, the small intestine is where all absorption takes place. So food goes in your mouth, down your esophagus, through the lower esophageal sphincter, into the stomach. From the stomach, it goes through the pyloric sphincter, into the small intestine. Small intestine is DJ ileum, duodenum, jejunum, and ileum. The ileum is the most distal part of the small intestine before you get to the large intestine. And with opioids, it can freeze, seize up. That is a paralytic ileus. When you assess a post-op patient, listen for bowel sounds in all 4 quadrants. If you do not hear any bowel sounds, not hypoactive, I said absence of bowel sounds, you will listen for a full 5 minutes per quad, because this is an urgent situation if you don't hear bowel sounds. You hear no bowel sounds after 5 minutes, you call that doctor immediately. That patient is NPO because they have a paralytic ileus, okay? Save their life, right? So with all opioids, you're going to teach about increasing fiber in the diet because of the constipation. You're going to teach about encouraging and increasing fluid intake for 2 reasons. 1, because of the constipation. 2, to help their body excrete the drug, right? Fluids, you want to drink, make sure you drink. And how much fluid? A normal, average, healthy human adult should be taking in somewhere between 2,500 and 3,500 milliliters of fluid a day. Okay? 2,500 to 3,500. And that's not if they have a fluid restriction like congestive heart failure. Okay? I'm talking about a normal, average, healthy human adult. Okay? All right. And if a patient were to overdose on an opioid, we have an opioid antagonist, and that is naloxone. Naloxone blocks the opioid receptors, so it immediately blocks the effects of the opioids. So we keep naloxone in PACU, post-anesthesia care unit, which is where people go after they have surgery. That's where they shake them and wake them. Wake up, Mrs. Jones, you awake? And in case they don't wake up on their own, we can give them naloxone. Now understand that if we do administer it in that setting, when the patient does open their eyes and wake up, they're going to be in pain because the Narcan, the naloxone, has blocked the opioids. So they're going to feel pain. I'm sure you understand that. And then understand something too, if it's a situation where you're on the street, and this is a board question, which is why I go over this, and you come upon someone or you have a family member that has overdosed and they're in respiratory arrest. They go into respiratory arrest before cardiac. Opioids slow the respirations down to the point where they stop breathing. And then their heart's going to stop beating. But they stop breathing first. You give them the Narcan, they're awake, you still must call 911 because you have no idea how much of the drug they've taken, right? Whether it's heroin or whether it's pills. And what can happen is the naloxone can wear off and they can overdose again because there's still opioid in their system. You always, always call 911 after administering naloxone in a private setting, private meaning in the home or on the street, okay, not in a facility. Okay, I'm going to pause for a second. So let's talk about infection. Make sure that all of you understand infection and the chain of infection, how infections are transmitted, okay? So the chain of infection is very self-explanatory. You must have some type of a pathogen. A pathogen is a bacterium or a virus or a spore, a mold, a fungus, right? Anything that has the capability of causing sickness or illness or harm to a human is a pathogen, okay? If we say something's pathogenic, it's harmful to you. So you have to have a pathogen. The pathogen has to live somewhere, right? That's the reservoir. The pathogen has to have a way to get out of where it's living. An example would be if I'm infected with a virus that's transmitted, say, by droplet, the portal of exit is me coughing. The droplets exit my mucous membranes of my mouth and shoot out 6 feet or so. Now you got it, right? So that's the portal, the exit, right? And then there's got to be a portal of entry on somebody who's a susceptible host. A susceptible host is someone who has some type of compromise in their immune system. They're susceptible. So if they're in contact with the person that has that pathogen, they are likely to get that pathogen. What makes somebody susceptible? Well, skin that's not intact. Because your skin is your #1 defense mechanism. It protects you. That's why we're always yelling, skin integrity, skin integrity, skin integrity. Because if you have an open area in your skin, that is a portal of entry where a pathogen could get in and infect you, right? It's one example. So you want to make sure that the person, compromised skin integrity is a huge risk for infection. If the patient has other illnesses, right? Sicknesses, illnesses, comorbidities, we call them, that make them immunocompromised. Example, HIV. HIV attacks the immune system itself. Somebody with HIV is automatically immunocompromised. They don't have sufficient white blood cells to fight off infection. A person who is receiving long-term corticosteroids, prednisone, methylprednisolone, they suppress the immune response, and that would make the person more susceptible to pathogens. A person who is being treated for cancer with chemotherapy or radiation, those are immunosuppressants. That would make that person susceptible, okay? And most comorbidities, like respiratory comorbidities like COPD, right? Even just being older makes you a higher risk. The very old and the very young are always fragile, okay? They are always a higher risk from an immuno standpoint, okay? So those are all your susceptible hosts. And while we're talking about that, if you do have somebody who's susceptible, who's immunocompromised, always remember neutropenic precautions, okay? Neutropenia means a depressed white blood cell count. So neutropenic precautions, no uncooked or undercooked food, no fresh fruit, no fresh vegetables. They shouldn't have flowers, live plants, anything that can carry a pathogen with it, right? None of those things. If they must go someplace, they must wear a mask, avoid crowds. Those are neutropenic precautions. You must know that, okay? They used to call it reverse isolation because we're protecting the patient from us, not the other way around, okay? And so let's talk about transmission-based precautions. Transmission-based precautions means what precautions do I have to use based on what kind of disease the person has and how is it transmitted. So in other words, we have universal or standard precautions. What that means is that if we anticipate being exposed to blood or body fluid, you wear gloves. You wear gloves. You just make that assumption that everybody got something. So you wear gloves, you protect yourself. Universal, standard precautions, right? You do not wear PPE like gloves to take vital signs. Okay? That is insulting to a patient, because if there's nothing open, if they don't, I mean, if they have wounds that are oozing, yeah, wear gloves, right? But if you're just going to take vital signs on a patient and you're wearing gloves, how come no one else is wearing gloves? You're going to make them feel like, you know, maybe they have something and they don't know it, right? Okay, you don't need gloves for that. Blood and body fluids. Contact precautions. Talk about different types of diseases that are transmitted by touch, right? You have to come in contact with something from that patient, like drainage from a wound, right? You have to come in contact with urine, with vancomycin-resistant enterococcus, VRE, is in urine. Contact precautions. MRSA, methicillin-resistant Staphylococcus aureus, when it's in a wound, would be contact precautions. So for contact precautions, you must wear gloves, maybe a gown, maybe even more than that, depending on clinical judgment and the task that you're going to perform. If you're going in to do a wound irrigation, the potential exists that it might splash when you're irrigating. So then you may want to wear a face shield, goggles, right? You don't want that splashing in your eyes or your mouth. But if you're going in to take a breakfast tray out, right? You see what I'm saying? Clinical judgment is inwoven in all of these things as well, okay? So contact precautions, anything. C. diff, Clostridium difficile, contact. Definitely wear gloves, probably gown, okay? Varicella is the disease that is transmitted airborne. And when the vesicles are oozing, contact also. Make sure you know that. Varicella, the chickenpox, if they are oozing, then it's contact. Otherwise, it's airborne. Okay? Speaking of airborne, the airborne diseases are MTV, right? Measles, aka rubeola. Measles, the medical term for measles is rubeola. You must know that. Mumps, oh no, not mumps, sorry. TB, tuberculosis. TB is airborne, and then varicella, which we just talked about, which is chickenpox. MTV, they're airborne. And what does that mean? They don't have to be coughing or laughing or sneezing or anything. They just need to be there breathing. And just that alone, they're breathing, airborne. Those droplets are microscopic and they're in the air and they can travel for indefinite periods. So all the air around them, highly contagious. Measles, tuberculosis, varicella. So you need an N95 fitted particulate respirator mask, not a one-size-fits-all surgical mask. An N95 fitted particulate respirator is what you, the nurse, wears. Okay? Patient needs to be placed into an isolated negative pressure room. That's a room where the air is literally sucked out and through a very specialized type of filter that filters out the pathogens. Okay, so negative pressure room. If by some chance the patient needs to be transported because they need an X-ray or a CT scan or something, surgical mask on the patient. And I tell you this, and this is a question people will ask, well, why just a surgical mask? You're not going to make them leave their room. You're not going to let them leave their room until we've started treating them, right? So that's why the risk is a little bit lessened at that point, because now they've started receiving treatment, which is always more than one antibiotic. But the two you need to know, rifampin and isoniazid. And both of them can be damaging to the liver, hepatotoxic. Rifampin can turn all body fluids red. Tears, saliva, urine. You want to make sure that you tell your patient that in advance, not that they start taking it and then they're watching a sad movie and they start to cry and it looks like they're crying blood and they think that they've turned into a vampire, right? So make sure you know rifampin and isoniazid. They're treating tuberculosis. And why must we always use more than one medication? You will never see someone with active TB or even latent TB treated with just one med. It's always a combination because of the resistance of the drug, of the bacteria rather, right? And bacteria are living creatures, not like viruses. So they are independent living things. They can mutate. That's how we wound up with MRSA and VRE. We had bacteria that got exposed, little tiny bits, but just enough to become resistant to certain antibiotics, right? And so now they're superbugs, MDROs, multi-drug resistant organisms, right? That's MRSA and VRE, okay? All right, we're doing good. So we talked about contact, we talked about universal, we talked about airborne, and last but not least is droplet. If it's not MTV and it's respiratory, then it's got to be droplet. Pneumococcal pneumonia, droplet, right? The flu, achoo, or cough, cough, right? Droplet. Droplet precautions. It was always 3 to 6 feet. I know that there's new information now that they've done these ultraviolet tests in black light, and they've shown that sometimes these droplets can go as far as 12 feet. But the Board of Nursing is still at the 3 to 6 feet stage. So that's the one you want to keep in mind. You only need a surgical mask, just a regular mask. You don't need an N95 for the droplet transmission. And they don't need that negative pressure room. If you have 2 patients that have the same disease, that is droplet or contact, they can share a room, not airborne. Okay. Just think about airborne is like the high and mighty of the types of transmission-based precautions. Going in a private room, it's a negative pressure room, the end. If you have 2 people with C. diff, you can have 2 people with C. diff share a room. Okay, make sense? So that's that. And while we're talking about infections, let's talk about the other types of anti-infective medications. So you have the queen mother of all antibiotics, the first antibiotic, penicillin. Penicillin is a broad spectrum antibiotic. So in other words, it treats all types of bacteria. And antibiotics only attack bacteria. They don't attack viruses. They're useless. So if you have a cold, that's a virus, the rhinovirus, you don't need an antibiotic because it won't do anything except contribute to more multi-drug resistant organisms, okay? So antibiotics, think antibacterial. They either slow their growth down or kill them, right? So penicillin, very first antibiotic we ever had. It's broad spectrum. It kills off a lot of stuff. And what you need to know about that, and all antibiotics, all of them can cause an adverse effect called pseudomembranous colitis. Pseudomembranous colitis. The symptom is frequent, watery, or even mucus or blood-tinged diarrhea, which they're getting C. diff. This is what's happening, okay? There is not an antibiotic out there that does not have the potential to possibly cause pseudomembranous colitis and or some type of GI upset, right? That's why I don't focus on that, because they all can cause nausea, right? So, but the pseudomembranous colitis, the frequent, watery, mucus-tinged or blood-tinged stools, now that's a problem because they could be developing Clostridium difficile. That is a bacterium that lives normally in your digestive tract. It's there, but the numbers of it are kept in check by the good bacteria that you have in there too. When you take antibiotics, sometimes, especially with the broad spectrum antibiotics, they're killing off the bad things that are making you sick, but they're killing off some good stuff too. And so what can happen is the C. diff can sometimes start to overgrow, and now you have a supra infection. Okay, so you want to tell your patient, if in fact you develop that type of diarrhea, you are to call the doctor. That's the one time where call the doctor is the right answer. Okay, he's developing C. diff. And speaking of C. diff, metronidazole, aka Flagyl, is the anti-infective of choice for C. diff. What do you need to know about metronidazole? You need to know that it will turn body fluid, urine, brown. So you always want to warn your patient about that, not that they start to urinate and it's real dark brown and they think that they've got something else horrible going on, right? And metronidazole, they need to stay away from alcohol or any products that contain alcohol because they will become ill. So when we talk about products that contain alcohol, lotion, moisturizing lotion, some mouthwashes, those kinds of things. You have to read labels and make sure that whatever they're using, some antiperspirants and deodorants contain alcohol. They need to stay away, refrain from any alcohol. And by the way, when you see E-T-O-H, okay, the letters E, T like Thomas, O-H, that is the abbreviation medically for alcohol, like alcohol, okay? So no alcohol with metronidazole, no, and brown urine, okay? That's that. And then back to the penicillin. The other thing penicillin can do, and amoxicillin, the cillins, furry tongue, hairy tongue. Their tongue will actually it'll look black and furry. Side effect, it's not going to kill anybody, but just know that. All right, fluoroquinolones. Oh, no. Before I go to fluoroquinolones, cephalosporins. Because the cephalosporin antibiotics, if you're allergic to penicillin, then you have a cross sensitivity to the cephalosporin. So if you're allergic to penicillin, you're allergic to cephalosporins as well. And the cephalosporin classification, all of them start with Ceph, either C-E-F or C-E-P-H. Cefepime, ceftriaxone, cephalaxin, right? Those are the cephalosporins. So if your patient's allergic to penicillin and you see the doctors prescribe them a cephalosporin, don't give it. You can call the doctor and say, hey, were you aware they're allergic to penicillin? You sure you want to give them cefepime? Right? Okay, that's that. Fluoroquinolones, the one you need to know, ciprofloxacin. And ciprofloxacin is used for urinary tract infections very commonly, okay? What do you need to know about ciprofloxacin? You need to know about Achilles tendon rupture. Tendinitis is an adverse effect of cipro, potentially. So if you have a patient that's a jogger or a runner, anything that's high impact on the lower extremities, tell them, don't do that while you're on the cipro, please. Because if you rupture your Achilles tendon, whew, takes a long time to heal. Very painful thing, okay? So that's that. And also with cipro, do not take with food or milk. Need to know that. That's fluoroquinolones. We can talk about the sulfonamides, and the one you need to know, trimethoprim sulfamethoxazole. Trimethoprim sulfamethoxazole, combination drug, also known as Bactrim, also known as Septra. Drug of choice for urinary tract infections. Drug of choice also, just like Cipro for urinary tract infections. But if your patient's allergic to sulfa, they can't have it. Sulfa's right in the name, right? Right in the name. So that makes that one, in my mind, kind of easy to remember, that it's got a sulfa base, okay? And big thing with the sulfa drugs, fluids, make sure they're drinking fluids. Crystal urea is an adverse effect, okay? So crystal urea, just like the name implies, when they urinate, it's like there are little crystals in it, like rock salt is what it looks like almost, right? And it's a problem with when the kidneys are trying to process the drug, they can actually, it can slow down kidney processing, and then they can have these hunks of crystalline uric acid and different types of acids that are in the kidneys that actually come out in the form of crystals in the urine. They need to increase their intake of fluid, okay? And like I said earlier, 2,500 to 3,500 milliliters of fluid a day for a normal, average, healthy adult, okay? So that's the sulfonamides. Tetracycline, and under that you've got doxycycline. So when you see the cyclines, right, they're not good drugs. The cyclines are last resort meds. They have a lot of side effects. The one thing I want you to remember, and this is a board question and an ATI question, never give tetracycline or any of the cyclines to pregnant women or a child that's 8 or younger, because it will permanently discolor their teeth. I see people going, right, it'll permanently discolor their teeth, and no one wants that, okay? Antifungals. Now, the antifungals often, not always, but often will end with ZOLE. But then again, proton pump inhibitors end with ZOLE. So this is one of those times, it's not like the beta blockers or the LOLs and the ACE inhibitors or the PRILs. You have a couple categories of meds that end with ZOLE. Antifungals, ketoconazole, miconazole, right? Those are antifungals. They can be oral, they can be topical, right? Then there's one antifungal, nystatin, swish and swallow for candidiasis. So if the patient has oral thrush, candidiasis, the white plaque inside the mouth, they're going to use nystatin, swish and swallow. Swish and swallow. It's right there in the way I present it. Put it in your mouth, swish it around like you're gargling, and then swallow it. Okay? Antifungal. Because candidiasis is a fungus among us. Right? Vaginal yeast infections, which can come as supra-infections from long-term use of antibiotics. You're baking bread down there, which is no fun. Miconazole. It comes in an ointment, right? That can be used. So those are the antifungals that you need to know. Antiviral. Cool, because they end in VIR. The ones you need to know anyway. Acyclovir. Acyclovir, VIR. So that's right there telling you, oh, this is for a virus. It treats the virus. They're still, you know, with COVID-19, using remdesivir, which is also an antiviral, with, you know, it's not completely approved yet, but they're using it for some people that are very ill with COVID, and they've been having some positive response, but the jury's still out. But anyway, VIR, antiviral drugs. Cannot stop the virus. No antiviral drug can kill the virus. It will slow the effects of the virus down if it's given quickly enough. So acyclovir, used for viruses like the herpes, right? Herpes simplex, fever blisters, right? That's one, herpes simplex 1. And then you have herpes simplex 2, the gift that keeps on giving, which is contagious whether you have an outbreak or not. Remember that. Even if you can't see it, it could still be lurking there. Condom, 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 condom. And then the herpes 3, varicella, which leads to herpes zoster, chickenpox, which can lead to the shingles. Okay, they're the herpes. They're viral, right? Hepatitis A, B, and C. There are others, but you don't need to know them, right? The 3 hepatitis they're viral. Okay, the flu, virus, rotavirus, stomach bug, virus, rhinovirus, cold, virus. They're viruses. Viruses are self-limiting. Viruses must run their course. That's what self-limiting means. That a virus, when it gets into a susceptible host, needs that host to live, number 1. And number 2, it's going to fizzle out. So it's going to run its course. It's self-limiting. The problem with things like COVID, like we're seeing now, is that for some people that are already compromised, before it's done running its course, it kills them. So that's the issue there. That all viruses are self-limiting. They will run their course. And the antiviral drugs, if given soon enough, can slow down the symptoms and make them not as severe. But it's not going to stop the virus. Okay? So anti-tubercular, antiviral, antifungal, antibiotic. I'm going to take a quick break and take questions. So do that right now. I'm going to pause recording. Okay, let's move on to musculoskeletal. Now, musculoskeletal, there's a lot of information, but I'm going to kind of just group things together, okay? So let's talk about osteoarthritis, rheumatoid arthritis, osteoporosis. We'll group those 3 things together. Osteoarthritis comes from aging. It is wear and tear on the joints and inflammation that occurs in the joints that is painful. Rheumatoid arthritis is an autoimmune disorder where the patient's immune system attacks their joints. Okay, so they are two completely different disease processes. If you hear somebody say, oh man, I have such bad arthritis, they're talking about osteoarthritis, right? It comes with age. And with osteoarthritis, you know, there's not a whole lot you can do as far as prevention with that. But you want to tell older people to avoid high impact activities because that puts wear and tear on your joints, like your knees and your ankles, right? Boom, boom, boom. Aerobics, boom, boom. Running, boom, boom. Jogging, boom, boom, right? You know what's great for people with osteoarthritis? Aerobics in water. Any exercise in a pool in water, because when you're in water, you're buoyant and there's no impact, right? We all float. I didn't believe it, and I didn't float until I was 42 years old because I'm from South Philly and we did not swim, right? I thought for sure I would just like sink to the bottom, but I didn't. I could float. They're telling the truth. Anyway, water exercise for people with osteoarthritis is fabulous, right? Because they're buoyant and there's no impact on the joints, okay? And so osteoarthritis, aging, inflammation in the joints, anti-inflammatory drugs to help with the inflammation. Warmth makes it feel better. Cold makes it feel worse. Okay? Rheumatoid arthritis. If you see somebody with rheumatoid arthritis, one of the telltale signs is, especially with the hands, their hands are gnarly. That's the best word that I find descriptive enough. Their joints are so inflamed and swollen. In the PowerPoint that I made, you'll see I put pictures of people's hands that have rheumatoid arthritis. So that's an autoimmune disorder. And so treatment for rheumatoid arthritis, yes, anti-inflammatories, but also immunosuppression. So for people that have rheumatoid arthritis, it's really bad. We'll suppress their immune system and stop their white blood cells from trying to destroy their joints, right? And with rheumatoid arthritis, hot and cold, right? Heat and warmth. When they're having a flare-up, the joints are red, inflamed, angry looking. So cold will actually decrease the inflammation. So sometimes alternating heat and cold. But remember, for those treatments, always you need a physician's order. And you always want to be very careful with answers that include like a heating pad or a cold compress, all right? Because if the patient has any neurological issues like diabetic neuropathy or peripheral vascular disease where their sensation in their lower extremities is diminished, never put a heating pad on them because they can't feel it and they'll get burned, right? Okay. So rheumatoid arthritis, osteoarthritis. Now, osteoporosis, that porosis, porous, it is a weakening or a brittling of the inside of the bones. And the most likely candidates are postmenopausal women. As estrogen levels decrease, that's what happens after menopause, calcitonin levels get screwed up. And when calcitonin levels get screwed up, the amount of calcium in your bone tends to be depleted. And when that happens, the bones will get brittle and they break easily. People with severe osteoporosis can just sit down, literally just, sit down and break a bone. Boom. They don't need a traumatic event for a bone to break. So can we help to possibly prevent it? We can. Osteoporosis can be preventable. How, you ask? Good question. Well, number one, when you're young, you want to make sure that you're working on muscle mass, weight-bearing exercises, things like lifting weights, things like walking, right? Not bicycling, not running or jogging, right? We're talking about building muscle because if you've got good muscle mass, that helps to keep the bones stronger, okay? Number one, you need sufficient calcium in your diet. And calcium in your diet, well, dairy products, right? We always think about things like milk, right? Cheese, yogurt, lots of calcium. Then you also need vitamin D to absorb calcium. Vitamin D, the sun. 15 minutes a day, 3 times a week is the bare minimum that you need in order to have vitamin D activated in your body, which will help your body to absorb the calcium, okay? Those are important things to know. And sometimes postmenopausal women will receive an estrogen supplement, which is hormone replacement therapy. Because after menopause, that's when, you know, your little shop inside shuts down, quits. All the little people that are non-essential employees get fired. All right, we're done here. She's not making any more babies. Your estrogen levels go down. And for some women, as long as they are candidates for hormone replacement therapy, because there are risks involved with estrogen, taking estrogen supplements, if indicated, can help to prevent osteoporosis too. But estrogen supplements, again, are dangerous because of things like female cancers and heart disease, which we'll get into that later for my Term 3 students, okay? Just know that when it comes to osteoporosis, yes, we can prevent it by building muscle mass, staying strong, weight-bearing exercises, calcium, vitamin D, right? And it's the postmenopausal women who are at risk. Okay, so that's that. Alendronate is the drug that we use to treat osteoporosis. It is a biphosphonate drug. It is taken weekly, and the number one adverse effect that it can cause is erosive esophagitis. It can literally eat away at the very smooth mucosal lining of your esophagus. So alendronate is taken once a week with a full glass of water, all by itself, and the patient must be able to sit or stand upright for a full 30 minutes after they take the drug. That's what you need to know about alendronate, okay? They may not lay down. They have to be in an upright position for a full 30 minutes after they take it, okay? And that is osteoporosis and rheumatoid arthritis and osteoarthritis. All right, let's go to, we'll go to hips and knees, okay? So fractures, okay? Let's talk about fractures first. So when a patient breaks a bone, a fracture is a broken bone, but there are lots of types of fractures. Fractures can be displaced or non-displaced. In other words, if this is my bone, imagine this is a bone, and I break it, and you got 2 pieces of bone that are no longer near each other, that is a displaced fracture, okay? If I fall and I get what's called a hairline fracture, that's a crack in the bone. So the bone is not in 2 separate pieces, but there's a crack in it, okay? So that's displaced versus non-displaced. If I have a displaced fracture, and when old people fall down and break a hip, they are getting a fracture of the head or neck of the femur, that big long bone in your thigh that articulates with your pelvis ischium, that's the hip. So when they fall and they break a hip, they usually have fractured the head or neck of the femur. If it is a displaced, and it usually is, fracture, well, we have to reduce it. Open reduction internal fixation, ORIF. Open, we cut you open. Reduction, we take the displaced fracture and put it back the way it was supposed to be. That's the reduction. Internal fixation, we use screws or plates, pins to hold it together. And then we close you up. That is an ORIF, open reduction internal fixation. These patients have very specific post-operative instructions. They should never, never, never bend at the waist, because when you bend at the waist, you are bending at a 90-degree angle. 90-degree hip flexion means bending from the waist to pick something up off the ground, right? They shouldn't do that, because if they do it, boom, they can pop up the hardware and wind up back in the operating room again. They should always use elevated seating, elevated toilet seat. When they're lying in bed, they should always use an abduction pillow. Abduction is apart. Adduction is add together. They should never bring their feet together. They should never cross their legs either at the ankles or the knees, because doing that, boom, they're going to pop out the hip. Okay? So no bending at the waist, no 90-degree hip flexion. There should be, elevated seating, abduction pillow when supine, all those things. Assistive devices like walkers, right? Ambulatory assistive devices. And that's ORIF. Then we have knees. Now, knees can go bad just because of wear and tear, osteoarthritis, right? And so your knee particularly, you've got the patella, kneecap, you've got the femur coming from the thigh, and then you've got the tibia and fibula from the lower extremity, patella, and then you've got meniscus and tendons and all kinds of stuff inside. The point is that sometimes with osteoarthritis, there can be such significant wear and tear on the knee that the patient requires a knee arthroplasty. And that's where the surgeons will go in arthroscopically with a scope, so they'll have puncture wounds, or they can do an incision. And they go in and they do what they'll call a knee replacement. Like, I got a total knee, I got a new knee, right? And so when a patient has a knee done, one thing you have to think about is that CPM machine. Oh, you got to know that continuous passive motion machine. Continuous passive motion machine is a wonderful gadget, because before they came out with them, we all took turns doing passive range of motion on the patient. Okay? Do you know what a pain in the neck that was? So I go in for 15 or 20 minutes with one hand under your knee and the other hand under your ankle, and I flex and extend, and I flex and I extend, and I flex and I extend. Well, now we have a machine that does it. CPM, continuous passive motion. So the machine is placed on the bed with a sheepskin liner, and only a sheepskin liner on it. That's it. And the patient's leg is on it. The settings are controlled by the doctor and the physical therapist. You don't have anything to do with that, okay? And the whole idea of it is with the flexion and extension, inside the knee joint, in the bursa, right? There's something called synovial fluid. And synovial fluid in your joint is like oil in your car, keeps it lubed, right? And so in order for that synovial fluid to continue being made, the knee's got to keep moving. So by putting you on the CPM, keeping your knee lubed up and making the pain decrease and making it heal better. That's the whole objective of the CPM machine, okay? So know that you never, ever, ever store anything, not the CPM machine or any other equipment for that matter, on the floor or on a windowsill in a facility. That is a no-no, okay? Never. And understand that when it comes to safety, this is common sense, but I'll throw it out there anyway. When it comes to safety, if there's any issue with the electrics of the machine, in other words, the cord is frayed or the machine feels warm or hot to the touch, get it out, tag it, and get them a new machine, right? You don't want the room to catch on fire with the patient in it. That would be bad. Okay. All right. I want to talk about traction, so I'm going to go back to the person with the hip, and I'm going to talk about Buck's traction first. Buck's traction is used to relieve muscle spasms and pain for a patient with a hip fracture prior to surgery. Buck's traction is used to relieve muscle spasm and pain for a patient with a hip fracture prior to surgery. What you have is a boot-like thing on the patient's extremity that's attached with a rope to a pulley to weights, and it keeps the leg pulled, right, with the weights. Remember, don't touch the weights. Don't touch them at all. The weights should be free hanging. They should not be touching the floor. If you see a question where one of the answers is the weights are nearly touching the floor, that's okay, as long as they're not touching the floor. So don't be tricked or fooled, okay? Pay attention to detail. So Buck's traction used for pain relief prior to surgery, muscle spasms. With a hip fracture, they will get some muscle spasms. And if you have a patient that's, say, on Plavix or Coumadin or something, they can't go right into the operating room, can they? We have to wait a little bit. Maybe give them some vitamin K. Plavix, there isn't an antidote for. So do you understand that that's why sometimes we can't send them right in for the repair? So we'll put them in Buck's traction to help relieve the muscle spasm and pain. Okay, and I'm going to get to the different types of traction. So that is Buck's traction, just for pain and muscle spasm relief. Then we have skeletal traction. Skeletal traction is for healing, immobility, for over time, keep the bones in the right place so that they heal from a fracture. Example, I'm in a car accident. I fractured my femur, which by the way is one of the worst fractures. Clavicle and femur, woo, nasty fractures. And so they have to go in and do a surgical repair and maybe put in a rod, which is not uncommon, right? To get that bone reduced and back aligned again. And then they're going to put in these pins that go through the skin to the bone with a bar on them. That is an external fixation device, okay? External fixation, and they're going to be attached to skeletal traction. So the principle is the same. The leg is attached to a little boot-like thing that's hooked up to rope with pulley with weights. And it keeps that leg, that extremity, stretched out and immobile. The external fixation device and the traction. So it's not moving. Same rules apply. Don't touch the weights. The weights should be free hanging. Patients can have and are encouraged to have a trapeze. Trapeze is a triangle shaped thing that's over the bed that they can use to move their upper body around in the bed, right? If they have the upper body strength to do it, hopefully. So trapeze, yes, but don't touch the affected extremity. Don't touch the weights, right? And then now we're talking about pin site care with an external fixation device. And by the way, external fixation devices also include halo vests. Now a halo vest, same principle, you have this ring that looks like a halo around their head that has pins that go through the skin to the skull. And it's treatment for a cervical spine fracture. So if I fracture a vertebrae up here in my neck, in my cervical spine, I'm not supposed to be turning my head. So you put the halo device on them, and it's got bars and a vest. And if they need to look over there, their whole upper body has to look over there. Got it? So there's no rotation of the head. It keeps it still. The halo vest has a liner. The liner is like lamb's wool, sheepskin, kind of like what you put on the CPM device. Typically, the liner is changed in the hospital daily. Typically, the liner's changed at home. I mean, I saw another thing in ATI where the best answer was weekly, right? But remember, with nursing style questions, NCLEX questions, NCLEX style questions, it's the best answer that you have to choose from. It's not necessarily the best answer, because I know I wouldn't want that on my skin for a week, not changed. Utsaland. But, you know, make sure you understand with the halo vest, there is a liner that needs to be changed. But you also need to do pin site care with external fixation devices like the halo or the bar for the femur. You can have external fixation on a lower extremity or an upper extremity or up here for the cervical spine. Pin site care is always a cotton-tipped applicator that is sterile, one applicator per pin site. Use normal saline. When all else fails, normal saline will work for everything that you need to do, right? And you cleanse the pin site from the site in a circular motion outward, so away from the site of entry, okay? What would you expect to see at the pin site? Crusting, right? A little redness, sure. A little serous drainage, serosanguinous, sure. Why? There's a foreign object drilled through your skin, and your body doesn't like it very much. So your body is sending serous it's lymphatic fluid, like, hey, there's something sticking in us, like, can we do something about that? So it's very normal and it's expected to see a little bit of erythema, a little bit of serous drainage, which is clear to like a pale yellow, watery looking drainage. And if it's serous sanguineous, it's that with a little bit of blood tinged in it. These are all expected findings and they're fine, okay? If you see purulent exudate, which is green or yellow or thick, viscous, copious, lots of it, right? Smelly, that's an infection. That's a problem, right? But serous sanguineous drainage, a little crust, all of those things are expected and fine. You do your pin site care, and typically it is once per shift. Okay. Don't worry about skin traction. You'll never see a question about it again. Okay. I think for now, I'm going to pause the recording, and I think that was a pretty comprehensive. I know there's still more things to talk about, like casts and stuff. Let me real quick, just before we end this, let me just throw in casts and compartment syndrome, okay? You have a fracture, and they put a cast on you. The biggest nursing intervention, you're doing circ checks, circulation checks, neurovascular checks, right? If I have a cast on my upper extremity, you as the nurse, your priority is to assess the most distal body part from the cast. So if the cast is on my arm, you're going to my hand and you're looking at the color. Is the color the same as the other hand, or is it blue, cyanotic? That's bad. You're checking capillary refill. Capillary bed should be 3 seconds or less, should be the same on both sides. You are checking for pulses, right? You should be able to feel a pulse, and the extremity should be the same temperature as the other. So if both of my hands are cool, the one with the cast and without it, cool. But if one of them is cool or cold and my other hand is warm, not cool. That's an impingement of blood flow, right? And then the other thing is sensation. Can they move their fingers or their toes if the cast is on their lower extremity? And can they feel? You know, you touch, close your eyes, and when I touch you, I want you to say yes. Yes, 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 yes. Right? Do they feel? If there's any impingement on feeling, or if they tell you, you know what? I'm getting like pins and needles. That's a paresthesia. Pins and needles, that sensation of tingling and then numbness. Paresthesia is the word to describe that. And that means the cast is too tight. Okay? They can develop compartment syndrome, which is swelling and coldness, not heat. Heat is infection, right? Coldness is lack of blood flow. So make sure you differentiate those two things. And so what's going to happen when you anticipate the healthcare provider is going to either univalve or bivalve the cast. Basically, they're going to cut into the cast and kind of roll it down to relieve the pressure and restore the blood flow. Okay, they're not going to take the cast off. And speaking of casts too, if a person, understand casts are usually on for weeks, 6 weeks, 8 weeks, long time. People will complain of itchiness under the cast. Never, never, never stick something in the cast to scratch. Blow dryer, cool setting. Blow into the cast, okay? Now I think that's it because I can feel my voice is starting, so I'm going to stop the recording and answer any questions that you have.